Any complaints?
Patient was admitted to us. No, there was no bleeding at all. She was saying something, discharge is this.
Who attempted the termination? It was by somebody? Hello?
Ma'am is muted.
Hello?
Good evening, Charmila ma'am.
Good evening, doctor. How are you?
Yeah, ma'am, fine. How are you, ma'am?
Fine, fine.
Thank
Hi,
you, ma'am.
Charmila.
Hi.
Faculty, ma'am.
Hi. Thank you.
Thank you.
Swarupa here.
Hi.
After long time we are meeting again.
So you have been the master trainers in the other Zoom meeting also, ma'am?
No, actually, I didn't get time in the last quarter. So only I was on Sunday. I took up a program, and this is the second program I'm doing.
Okay.
Last year I couldn't do because I was involved with so many projects. So this time when they asked, I accepted because I
We were there together in one of the CMEs.
okay.
Webinar, in webinar.
Okay.
Okay,
In
ma'am.
one of the webinar.
It's raining so heavily here. My network is going and coming. So I'm just taking my toggle.
Okay. Which place, ma'am? Charmila ma'am and Swarupa ma'am?
It's a Trichy in Tamil Nadu.
Okay, okay, ma'am. Okay.
Yeah, and
Swarupa
I'm from
ma'am?
Mancherial, Telangana.
Telangana. Okay, okay, ma'am. So nice, ma'am. All are from different states today.
Yeah, nice. See, that is the beauty of this
Webinars.
Correct.
these Zoom meetings.
Yeah, we got to meet
Good
so
evening,
many people.
Jamila ma'am. How are you?
Hi, fine. How are you?
I'm fine, ma'am.
Yeah.
Yeah, Swarupa ma'am, you was asking something. Actually, my network
Yes.
not stable.
No. Actually, wondering how it came into the bladder and did they attempt an
Actually,
again?
I consulted the MRI was done, and there was head in the bladder because we are outside. She has undergone the manipulation. They told that only the legs and up to the trunk has come out. MRI was done and the head was inside the bladder. Yeah, and then cystoscopy was done by the urologist only.
So it was a perforated uterus and a perforated bladder.
Actually, ma'am, I want to discuss that because obviously there was perforation in the uterus only, then only it can go to the bladder. When cystoscopy was done, my urologist was observing only the anterior surface. Then I said, you watch the posterior surface because your posterior surface and mine anterior, they are actually into each other. Then we traced towards the posterior surface and there was a big rent. And later on, we put the dilator, and that dilator came out from the cervix to the bladder. And then we opened the abdomen, and incision was given anteriorly on the bladder, and it head was taken out with the sponge holder, and then the rent was stitched on the posterior surface, then anterior surface, and there was very small rent on the cervix, which was very small, and it was totally fibrous. There was no bleeding at all from that. I'm having videos also of that. We have preserved that.
Nowadays it's happening. It's very frightening because this was 10-15 years back. We had such cases. It's very rare
46
nowadays.
years, patient was 46 years, ma'am, and previous 3 cesarean. I want to publish that in Jogi, but I don't know they will publish or not. I don't know.
It's a rare case. Definitely, they might be considering.
I don't know. I will send definitely. I have prepared the case and I'm going to send that paper to them. I don't know whether it
You can send it to other journals also.
Yeah, ma'am. Any journal you can tell me?
I'll just check and tell you because
Okay.
case reports, Jogi, usually they have little this thing. It has to be very, very rare or it has to have some clinical implication. Otherwise, because these type of cases, usually I have not seen them this thing. But I'll just check and tell you.
Okay, thank you so much.
We can start, no? It's already 6.
Yes, ma'am. One more faculty, Mr. Steeman, Apurva ma'am has joined.
Apurva sir will join in soon, madam. I spoke to him. He said he'll join in soon.
He's joining. He's just joining.
Okay.
Yeah, I'll just join you back very shortly. I'll just come back.
Okay.
Hi, Apurva. We are all waiting
Shamila
for
ma'am,
you.
good evening.
Hi. Good
Good
evening.
evening, Apurva sir.
Hello.
So
Ha,
we-
yeah, Sushma ma'am, hello.
Good
Shangita
evening, sir.
madam,
Hello, Dr.
namaskara,
Apurva.
good evening.
Thank you, sir, for being our faculty today.
Thank you so much, ma'am, for inviting me. It's
Thank
really
you.
an honor.
Thank you, sir. Thank you, all the faculties. So, shall we start, Mr. Shriman, or shall we
Madam.
wait?
We'll wait, madam, because only 4 participants have joined it.
Okay, okay.
So
We'll
we'll
wait.
wait for more 5 minutes and we'll start.
Yeah, yes, Mr. Shriman. Okay.
ನಮ್ಮ ದೇಶಕ್ಕೆ ಅವರು ಕಾಣ್ಕೊಳ್ಳುತ್ತೆ ತಂತ್ರಜ್ಞಾನದ ಪ್ರಭಾವ ಬೀರುತ್ತೆ ಅಂತ ಕಾಣ್ಕೊಳ್ಳುವಂತಹ ನಕ್ಷತ್ರವಾದ ಪ್ರಮಾಣ 23 ಅಂತ ಇನ್ನು ಪಾಶ್ಚಾತ್ಯ ದೇಶಗಳಲ್ಲಿ
Mr. Shriman, can we start now?
Yes, madam, we can.
Yeah. So good evening all. A warm greetings from the Foxy WHO for RAC project. Myself, Dr. Sushma, MKM, Secretary of Raichur Obstetrics and Gynecological Society. I thank all the faculties who have taken time today for being with us today. And I also thank Dr. Mangla Gadwal, President of ROGS, and all the members of Foxy who have joined today. So let us start the webinar. First topic will be Medical Termination of Pregnancy Amendment 2021 by Dr. Sangeeta Phava. Next will be Safe Abortion by Dr. Charmila IAO. WHO Saver Toolkit Safe Abortion Values, Evidence and Rights by Dr. Apurva Kumar Datta. And Pre and Post Abortion Family Planning Counseling by Dr. Swaruparani Akula. Sangeeta ma'am?
Thank you, Dr. Sushma.
Yes, ma'am.
Kind words, and it's my pleasure to be on this platform. And I'm really happy that today we are going to discuss a very important topic, that is RAC. We are doing abortion since a long time, but this is really a good term, that RAC, respectful abortion care, which is very, very important, because we have to maintain the dignity of the patient as well as confidentiality of the patient, and how to tackle the patient. Because sometimes we are using the words which patient is not going to accept, and sometimes patients are saying the words which are not acceptable to us. So it's not like that. They have rights to ask us. It is reciprocal. If we want to take respect from the patients, we should respect the patient, not only for the purpose of the respectful abortion, for any purpose. We are going to respect the patient. So now, what are the objectives of this first module? We will take a closer look at what are the new laws. As we all know, first MTP Act came in 1971. It's since 50 years when we are coming with the new laws. What are the changes in the rules, and what is the need of these changes? Unsafe
I'm sorry to
abortion.
interrupt you, Sangeeta madam. It's not full
Yeah.
screen, madam. Click on this
Yeah.
enable. Madam, it's not full screen. Can you click on this enable editing button, madam, which is in the
Oh,
top?
yeah. Oh, sure. This is the third button. Now it's okay.
Yes, ma'am.
As we all know that unsafe abortions in India lead to mortality, morbidity, and hamper women and girls' full participation. What is unsafe abortion? Unsafe means whether you are doing, and see, I am doing in my clinic where I am not having even the basic facilities for resuscitation. Again, it is unsafe abortion. Even if I am eligible to do. So we should know what is the site where it should be done, who is eligible to do, and why it is to be done, and when it is to be done. All things should be in our mind before proceeding towards the abortion. Then it is only safe abortion. 8% of the maternal deaths per year occur due to the abortion. It is third leading cause of the maternal mortality. Near 2 out of the 3 of the abortions performed are unsafe. Nearly half of the pregnancy-related deaths are in women and girls under 24 years of age. So when is abortion considered safe? As per WHO definition, by appropriate methods and by trained persons. Then it is only safe when both the criteria are met. It is less safe when one thing is okay. It is totally unsafe when it is not appropriate method, not trained persons. So what is Medical Termination of Pregnancy Amendment 2021 law? It is safe and comprehensive care mandated by law. As we all know, when it is act, we have all to follow. Rule is, say I have made some rule in my family that everybody is coming at 10 p.m. If somebody is not following that rule, I can just say or threaten that you are not going to repeat this again. But once it is act, that definitely it is punishable. Either you will be behind bars or you have to pay for that. So we have to follow all the rules of the act, and opinion of one provider is mandatory. If MTP has to be done up to 12 weeks, it is the previous act. Now the new Act 2021 is saying that we can extend till 20 weeks, only one RMP can go for termination of pregnancy, no need for the second person's opinion. Requirement of the opinion of two providers for MTP for 12 to 20 weeks, that was previous one. And now requirement of opinion of the two RMPs for termination of pregnancy from 20 to 24 weeks of gestation. So what is the benefit? Definitely it is going to give us benefit, because in the PHCs as well as in the private hospitals, only one gynecologist or one RMP is handling all the cases. So there will be increase in the number of facilities, especially in the public sector, like PHCs, who are eligible for service provision till 20 weeks of gestation. And as we all know, level 2 or anomaly scan, we are going at 18 to 20 weeks of gestation. And one practitioner now is allowed to undergo this termination till 20 weeks of gestation. What is the vulnerable group modification? In the previous act, it is permissible beyond 20 weeks only, when it is immediately necessary to save the life of the pregnant woman. Now, 21 amendment has enhanced this limit to 24 weeks for special or vulnerable categories of women. Further enhancement for birth defects not compatible with life on medical board consensus. So up to 20 weeks in vulnerable categories, like violence victims, minor among others, we can go for this medical termination of pregnancy. This is the outcome, that there will be increased access for these vulnerable women for safe and legal abortion. Now, what is the modifications related to the marital status? Previously, we were saying only for the married woman or her husband. Now, 21 amendment is really good, which is saying that condition of the failure of contraceptive to be extended for any woman, whether married or unmarried or her partner. So what will be the potential outcome? Increase access to the safe and legal abortion for any woman irrespective of marriage age, especially because nowadays legal age of abortion marriage is coming 21 years, but patients are coming with pregnancy before that. So it will act for them as well. An important advancement for increasing access to the safe abortion, even to the unmarried girls less than 21 years of age. So insertion of the new clause for strengthening privacy, the medical termination of pregnancy regulation 2003 mentioned that information should not be disclosed except under authority of law. Name, and now 2021 is saying name and particulars of a woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. This is the very frequently asked question, that if we are not writing the name on the files of the patients, it's not like that, that we can disclose the identity to the patient only, not to the other females who are sitting on the other beds beside her. It's not like that to every other patient. We are saying that this patient has undergone medical termination of pregnancy, but when patient is going, definitely we are going to take signature of the patient also, that we are going for the medical termination of pregnancy, as well as when we are giving the discharges to the patients, again we are writing the discharge notes on that this patient has gone medical termination of pregnancy. What is the potential outcome? Increase in the privacy, confidentiality of abortion seekers, increased demand, but need to safeguard rights and dignity of the woman, and provide respectful bias-free services, including counseling and contraception. So confidentiality and safety is the priority. Name and particulars of any woman be confidential except to a person which is authorized by law for the time being in force. The ground of failure of the contraception has been extended to women and her partner. So it defines special or vulnerable category of women eligible for extended gestational period from 20 to 24 weeks. Norm for the RMP whose opinion is required for termination of pregnancy at different gestational ages. Powers and functions of the medical boards, which is consisting of obstetrician, pediatrician, and radiologist when available, formed for each state and mandated to provide timely evidence-based decisions. So there is special categories of women who are eligible for MTP between 20 and 24 weeks of gestation. One is the survival of the sexual assault, rape, or incest. Women with a pregnancy in the humanitarian settings, disaster, emergency situations. Thirdly, change of the marital status, whether she's widow or divorced. Women with a physical disability as per Disability Act, major disability per criteria. If patient is mentally ill, including mental retardation, minors, and fetal malformations that are incompatible with the life, or if the child was born, it would suffer from such physical or mental abnormalities to be seriously handicapped. So RMP, what is RMP? Defined in the old act as MBBS or more with any medical practitioner assisted in 25 cases of MTP, of which at least 5 done independently in a hospital, who has completed 6 months of house job in obs and gynae, who holds a PG degree or diploma in obs gynae, who has experience of at least 1 year in the practice of obs gynae. As we have already discussed, 1 RMP up to 20 weeks, 20 to 24 weeks. Beyond 24 weeks, we are in need of medical for opinion whether to terminate or not to terminate. Under the Rule 2021, an additional category of provider has been added for termination up to 9 weeks with experience in the practice of OBG at any hospital for 3 months, or training with performance of 10 cases of MTP by MMA under supervision of RMP in a hospital established or maintained or a training institute approved for this purpose by the government till 9 weeks. This is the hospital experience 3 months, 10 cases, and 6 months of house job, or has assisted in performance of 25 cases, of which at least 5 cases has been done in independently, PG degree or diploma. We have just discussed that up to 9 weeks, this is the experience and training requirement by the medical practitioner. And up till 12 weeks, again, 25 cases of the MTP, 5 has been done independently, PG degree, diploma, 1 year in the practice of obs gynae, 6 months of house job, and opinion of 1 RMP is required. Beyond 12 weeks till 20 weeks, experience and training requirement for RMPs, again, PG degree or diploma, 6 months of house job, and 1 year in practice of obs and gynae at any hospital who has experience at any hospital of 1 year at least. Again, opinion of 1 RMP is required. 20 to 24 weeks, again, PG degree or diploma, 6 months of house job, and a practitioner who has experience at any hospital, not less than 1 year. Again, the same criteria, but opinion of 2 RMPs is required here from 20 to 24 weeks. Beyond 24 weeks, again, PG degree, diploma, 1 year in the practice of OBGYN, but the opinion of medical board is required. For the termination procedure, when advised by the board, is carried out with all safety precautions, along with the counseling which is appropriate and place which is approved. So composition of the medical board, we have discussed. Powers of the medical boards to allow or deny, which is very, very important, and it is really a good, because sometimes we ourselves are in dilemma whether to terminate or not to terminate. When pediatrician is there and radiologist is there with us, then really it's easy whether we have to allow or deny the termination after 20 weeks of gestation, 24 weeks of gestation, due consideration and ensuring that the procedure would be safe for the woman at that gestational age, and whether the fetal malformation is such that it is incompatible with life, or if the child will be born, he or she will suffer from physical or mental abnormalities to be seriously handicapped. Co-opt other specialists in the board and ask for additional investigations if required for deciding on the termination of pregnancy. Recently, we have taken the opinion of the cardiologist and cardiac surgeon also when we have undergone termination of pregnancy, because patient was having Effenmenger disease. So functions of the medical board is to examine the woman reports, who would approach for medical termination of pregnancy, provide the opinion of the medical board in Form D with regard to the termination of pregnancy or rejection of the request for termination within 3 days of receiving the request, and to ensure that the termination procedure that should be done within 5 days of the receipt of the agree of the medical board and request for the medical termination of the pregnancy. I'm not able to move. Yes. I think this is the last slide, and FOXI has an important role to play in ensuring there are functional medical boards in every state, as it is stated in MTP Amendment 2021. But I still don't know whether we in Punjab we are having that state board or not. So this is my query. I hope so. Chamila madam is there and she will be able to answer, give my answer. Thank you so much for giving me time and listening to me with patience. In India, abortion is legal. Let us make it safe and respectful. Thank you so much.
Thank you, Sangeeta ma'am. It was a nice topic and nice talk, ma'am.
Thank you so much, Dr. Sushma.
Thank you, ma'am. So we'll go with the second topic, that is safe abortion by Dr. Charmila Ayavo. Over to you, ma'am.
Thank you so much, Sangeeta. There was a wonderful talk on the MPP Amendment Act, and this module is basically on how do you do the procedure? What are the technical guidelines for doing the procedure? Because everything needs a protocol, and there are so many protocols for safe abortion services, but the one by WHO is quite comprehensive, and everybody needs to know so that we don't have a medical legal problem at the end of it. I know that we can manage most of the situations quite clinically, but you have to be safe medical legally also, because we see women coming with so many problems, and they compel us to do sometimes outside the law, and that's why the module 1 is very important. And this is the updates in technology which has happened in safe abortion services. This will have an overview of the existing guidelines which are there, the pre-abortion assessment which needs to be done when you're offering this service, the medical methods of abortion which needs to be done in a particular manner, and the surgical methods of abortion. So these are the guidelines which have been brought out by WHO as different books over various years. It's happened from 2012 till 2019. And there have been handbooks on safe abortion. There have been books on safe abortion, care and post-abortion contraceptive services, and medical methods of abortion guidelines came in 2018. And the self-care intervention for health came out in 2019. And this is a roadmap of how WHO has brought out the safe abortion guidelines. The Ministry of Health and Family Welfare has also brought out guidelines on safe abortions. And the amendment was done in 2021, which was dealt by the previous speaker. And the law was changed in 25th March 2021. And the rules were changed in 24th September, and they came into vogue last year. So now all the guidelines have got 3 key areas in management of abortion safely. And that is a pre-abortion care which you offer a patient, the abortion care methods and techniques, and the aftercare and follow-up you should offer a lady, because when she comes for an abortion, it's the correct opportunity to utilize for counseling her regarding her future health. So when a patient comes asking for an abortion, she should be allowed to choose from all the methods available. And for that, you need to first ask her history. History taking is very important. And then examination is extremely important. Many of the youngsters nowadays do not do a physical examination before offering the service, but it's mandatory that you do a speculum examination or pervaginal examination before you offer the service. And when necessary, you may need to do some laboratory investigations, and always take the first opportunity to discuss the contraceptive options when she's coming for an asking for an abortion, because the decisions will be changed after she undergoes a procedure, and she'll not be willing to listen probably not as much as she listens before the procedure. So what is the assessment and counseling you will do before you offer the service? The components will be a detailed history taking. It should be quite comprehensive. You need to do a general physical examination and a pelvic examination. Investigations as and when needed needs to be done, and the decision has to be made by you, but the patient needs to have all the information possible on abortion procedures, and you need to have a counseling session also regarding the post-abortion care. So how do you determine the gestational age by the LMP, and how do you confirm it to the physical examination? This we were doing it quite often before ultrasound came into the picture, but every obstetrician gynecologist should be trained in being able to estimate the gestational age by a PV examination. Definitely we need to learn that, and we have to keep on learning and keep ourselves updated on that. And so when the pregnancy gestation age is around 8 weeks, it will be like a cricket ball. You'll be able to appreciate that when you do a pervaginal examination on an empty bladder. After 12 weeks, the uterus will rise out of the pelvis, so it will be palpable per abdomen. 16 weeks pregnancy is when the midpoint between the symphysis pubis and the umbilicus is around 16 weeks of gestation. 20 weeks is when the uterus reaches the umbilicus. And after 20 weeks of gestation, the fundal height can be measured in centimeters when you measure from the symphysis pubis till the xiphisternum. And that approximates the weeks in gestation. There are limitations to dating by just a physical examination when there's a uterine malformation like a bicornuate uterus, or there are fibroids in the uterus. Suppose there's a multiple gestation, you will miss the boat there if you just do a physical examination. A marked retroversion may not tell you the correct picture of what the gestational age is. If the lady is obese, it's going to add on to the problems. And if there's a molar pregnancy, you will miss when you do just a physical examination. But there are some considerations which you should always have when you do a pervaginal examination. And when the uterus is smaller than what you expected, it means that the patient may not be pregnant. If there have been inaccurate dating of her menstrual cycle, or there have been ectopic pregnancy or an abnormal intrauterine pregnancy in the form of a spontaneous or a missed abortion, when the uterine size is less than what you anticipated. Suppose it's larger than what you anticipated, then here also it may be an inaccurate dating, maybe a multiple gestation, maybe uterine abnormalities like fibroids, or there may be a molar pregnancy. So you have to keep all this in mind when you estimate the gestational age by just a physical examination and an LMP. So what are the investigations which are needed? Routine tests are definitely not needed, but sometimes you will need to do a pregnancy test if she has not confirmed the pregnancy before. If she looks pale and she's got features of anemia, you will need to do a hemoglobin. RH testing needs to be done, and you have to identify an RH negative woman, and if she's RH negative, you may need to give RH immunoglobulin. HIV testing and counseling sometimes needs to be done if there's a suspicion. A sexual transmitted infection screen may be done if you feel that she's got a pelvic infection. And suppose you suspect any other medical disorder, we need to do a renal function or a liver function test. Ultrasound is not so necessary unless you want to diagnose a pregnancy and you're not certain whether it's going to be a missed abortion or an ectopic pregnancy, then probably you will need to do an ultrasound. And what is a counseling? You will always have to ask about the thoughts about terminating the pregnancy and the reason for terminating. If you don't talk very clearly about this, you may have a problem later on. Inform that the abortion service is quite safe, and the importance of a trained provider in performing this procedure is very important. You have to tell her about all the available methods of abortion services. You have to explain to her the risks and warning signs associated with the abortion method, and have to emphasize that without contraception, she will get pregnant as quick as 14 days or 2 weeks after an abortion. But she can resume all her normal activities, including sexual intercourse. And you have to talk about the other follow-up care. She's got some other problem also. And always document, get her informed written consent before you offer the service. And you have to document her decision to accept a post-abortion contraceptive. But even if she's not willing for contraception, you have to provide abortion service. You cannot say no just because she's not accepting contraception. So up to 12 weeks of pregnancy, the medical methods which are offered are a combination of mifepristone with misoprostol. Rarely nowadays misoprostol only is given, or you can offer vacuum aspiration. If it's more than 12 weeks of gestation, other than vacuum aspiration, you have to now offer a dilatation or evacuation. But a sharp curettage is not recommended by the WHO. And up to 9 weeks of gestation, the medical method is little different from the pregnancy between 7 to 9 weeks. Here it's not mentioned correctly, but you give for both up to 7 weeks and 7 to 9 weeks mifepristone, 1 tablet, 200 milligram oral. Ask the patient to wait for a day, or at the best is wait for 48 hours. And then you give misoprostol 800 micrograms, sublingual, buccal or vaginal if she's 7 to 9 weeks. But if she's between less than 7 weeks, 600 microgram dose or a 400 microgram dose is quite enough for an abortion service. So what are the medical methods available and the surgical methods available for a first trimester abortion? The first drug is mifepristone, which we give. It's an anti-progestogen, and it inhibits the action of progesterone on the pregnancy, and hence interferes with the continuation of pregnancy. And after you give mifepristone, you'll have to follow up with misoprostol, which is a prostaglandin E1 analog, which will cause cervical softening, uterine contraction, and expulsion of products of conception. The advantages of the combination of mifepristone and misoprostol is And the protocols which are there is day 1, you give mifepristone 200 milligram oral. And suppose she's RH negative, you'll have to give the anti-D dose of 50 microgram at this point of time. After 48 hours, you call her, and suppose she's less than 7 weeks, you give her 400 microgram misoprostol. There's 2 tablets of 200 microgram each, sublingual, buccal, vaginal, or oral. But if she's between 7 to 9 weeks, the dose has to be doubled, and that is 800 microgram in any of those routes. In addition, for the pain, you may need to offer analgesics. And suppose she's having vomiting symptoms, she'll need an antiemetic. And here also you'll offer a contraceptive advice. And after 15 days, we'll have to call up for a follow-up to confirm and ensure that the procedure is completed. And now also you'll offer contraception. And how would the different routes of misoprostol usage, everybody needs to know, because there are different types of complications. Oral route, the side effects is diarrhea, nausea, fever and chills. The buccal route also will cause fever and chills, and it's much more than the vaginal route. In the buccal route, the drug is placed between the gum and the cheek, and then the patient is asked to swallow after half an hour. Sublingual route, when the pill is placed under the tongue and swallowed after half an hour. And in sublingual route, remember, it's got a high rate of increased fever, chills, and diarrhea and vomiting. But it has got one of the fastest onset of action, and it's got a highest plasma concentration level. The vaginal route, you place in the deepest portion of the vagina, and the lady is asked to lie down for half an hour. The problem is you have to tell her that pill fragments may be expelled after a period of time, but the lowest rate of side effects is always the vaginal route, and that's why it has to be advocated, because when you have a complication for a first trimester abortion in the form of fever and chills, it may cause more anxiety to the patient. So this is how the buccal route is given, when the tablet is placed between the teeth and the gums. Sublingual route is where the tablet is placed under the tongue. So what about the WHO drug regime for medical abortion? It's also similar to what the national guidelines say. That is, for less than 12 weeks, you give 1 tablet of mifepristone. 24 to 48 hours later, your misoprostol is given 800 micrograms. Does not differentiate between less than 7 and between 7 to 9 weeks of gestation. So 800 microgram is given for any pregnancy in the first trimester. And you have to tell the patient that there will be bleeding, which will happen for the next 2 weeks, and sometimes in rare cases can happen for 1.5 months. That has to be told to the patient. So the services need to be available at all primary care level, and any center which is providing the service at the primary care will have to have a referral system, because they need to refer the patient if it's going to be a complication. And additional services which may be provided even at the primary level is counseling and testing for sexually transmitted infections. Suppose there's a case of a sexual assault or abuse, you may need to offer the support services. Psychological or social services should always be offered, and sometimes you may need to offer specialist health or medical services. Suppose she looks anemic, you need to provide iron tablets. And suppose she's having pain after the procedure, you have to provide pain medications and provide emotional support whenever needed. And the follow-up care is not much when you've done an abortion service with mifepristone or misoprostol. But the recent guideline is, if you're providing the service with only misoprostol, you will need to have to call her for a follow-up visit, because you have to confirm that the procedure is complete. And even if you do with mifepristone, misoprostol, not only to check whether everything is complete, you may need to offer the support which she needs for her prevention of future pregnancy in the form of contraceptive counseling, emotional support, or address any medical concerns which she has. And when she comes for her follow-up, you have to assess the lady's recovery, ask for any symptoms and signs of an ongoing pregnancy, review her medical records, referral documents, ask about any symptoms experienced since the procedure, and perform a focused physical examination. Do not say nothing will happen. If she has a complaint, you have to go for a physical examination to confirm that everything is fine. And always assess her fertility goals and need for contraceptive services if not provided earlier. The summary will be, when she comes on day 1, a physical and pelvic examination, confirm the eligibility of what gestation age she is, when we need to offer the tablets for that. 1 tablet of mifepristone is enough. Offer anti-D if she's RH negative, and tell her to return for misoprostol after 2 days. Keep her address and phone number at the facility where she can go in case of an emergency. So you have to put it up in your OP so that she knows where to go in a case of an emergency. Record her experience of any side effect on the MMA card. And remember, 3% of the ladies may expel completely only with mifepristone. But in spite of that, you will have to complete the misoprostol schedule because many will not abort totally. And when she comes in the second visit 48 hours later, give her misoprostol, 400 micrograms sublingual, buccal or vaginal. That is when she's less than 7 weeks. When she is more than 7 weeks, you have to offer 800 microgram. Observe for 4 hours. Give her an analgesic in the form of ibuprofen, which is having pain. Contraceptive advice have to be advised. And tell her that she'll have a bleeding for at least a week to 2 weeks. Side effects which can happen are nausea, vomiting, diarrhea, headache, fever, dizziness. Suppose she has got excessive bleeding or pain, abdomen and fever, she has to report to the center. And also she has got no bleeding 24 hours even after misoprostol has been used, she will need to come again because you may need to give an additional dose of misoprostol. But 75% will abort in 4 to 6 hours after misoprostol. And when she comes on day 15, you will have to do a pelvic examination to ensure the completion. Contraceptive options have to be given. Tell her that she will have an immediate return to fertility, and that's why contraception is mandatory. And she has to report back if there are no periods in the next 6 weeks after completion of the abortion process. And you will need to go for an ultrasound if you want to confirm that the procedure is complete. If you've got a suspicion that it's not complete, otherwise it's not necessary. What are the side effects and complications? The pain which can happen with an abortion has to be told to the patient. And when she comes, you have to be respectful and give a non-judgmental communication. Verbal support is needed. Adequate counseling should be given. And support person should talk and explain to her about the procedure. Ibuprofen should be given if she's got pain. But if she's got persistent pain and there's a failure to respond to any drug you've given, then we need to evaluate to rule out an ectopic pregnancy, infection, or an incomplete abortion. She's got nausea and vomiting, you can reassure her that it's self-limiting. Diarrhea also, you can reassure that it's self-limiting. Suppose it's infection you're suspecting, then you have to confirm by physical examination and start appropriate antibiotics. And suppose there's a failure or incomplete result with the medical method you followed, then you may need to offer vacuum aspiration or repeat the drugs again. And suppose it's incomplete, it's not like failure means she has not aborted at all, then you may need to offer this. If it's incomplete and she's not having heavy bleeding, you can actually wait for the bleeding to resolve. But if it's very heavy, you may need to actually go for a surgical method. And sometimes an incomplete result, you can repeat misoprostol. But if it's not aborting, you may need to go for a surgical method again. And suppose she settles with just observation, you can just assume that it's complete. But heavy bleeding continues, you may need to check how much pad she's soaking in an hour. Suppose she soaks 2 pads in 1 hour for 2 consecutive hours, that means it's excessive bleeding. And suppose with observation, it just decreases over time, just keep a watch over vital signs. And suppose the bleeding does not decrease, then you may need to do a PV examination. And suppose a POC is on the cervical canal, you can just do a digital evacuation. And the lady is stable and the bleeding reduces, you can just observe her and monitor her. But if the bleeding continues, you may need to do an ultrasound. And suppose you see minimal residual bits, you can just wait and watch. But you've got products of consumption along with the residue are there, and the lady is not stable, you need to go for a surgical method and aspirate. Vacuum aspiration needs to be done. The lady is stable and there are products of consumption, probably you can use misoprostol again in the form of 600 microgram oral or 400 microgram sublingual. Because she's bleeding, you cannot use a vaginal route now. And when ultrasound, suppose it's a continuation of pregnancy, you need to go for a surgical method now. So what other forms you will maintain for a medical method? Form C, consent form, is mandatory. Form 1, the opinion by the registered medical practitioner is yourself. The Form 2, that's a monthly reporting form to the district authorities. And Form 3 is admission register you maintain for all the case records. So what about the surgical methods? It's a recommended technique for pregnancies which are bigger, and that is up to 12 weeks, 9 to 12 weeks. Probably vacuum aspiration is one of the better techniques. And WHO recommends a manual vacuum aspiration as the safest method, and you need not do a sharp curettage after you do a vacuum aspiration. And this is a technique which we do, and it's a handheld aspirator, and you have to generate the vacuum, and then the aspirator is attached to the cannula, and there are different sizes, 4 to 12 mm, and it can be used without electricity. That's advantage. There's the IPAS or easy grip cannula, which will correspond to the week of gestation. If you see an 8 mm cannula, you can use it for an 8 weeks pregnancy, and if it's 10 weeks, you'll need to use a 10 mm cannula. Or you can use an electric vacuum aspiration where you can attach the electric pump to generate the vacuum, and you can accommodate the cannula of manual vacuum aspiration here with the correct size tubing to the electric pump, and that will help you to do an aspiration. Cervical priming needs to be considered when you do for a bigger pregnancy or a vacuum aspiration or electric aspiration. And for that, you can use oral mifepristone 200 milligram, but that has to be given 1 to 2 days in advance. Suppose you use misoprostol 400 microgram, sublingually it can be given 2 to 3 hours before the procedure. A vaginal route can be given 3 hours prior, 200 microgram, or you can use a laminaria trent placed intracervically 6 to 24 hours prior to the procedure. And pain management is very, very important in surgical procedures, and it can be non-pharmacological or pharmacological. Non-pharmacological, you have to keep on talking to the patient so that she feels comfortable, to explain to her every step in advance because she's conscious. Please perform the procedure gently and smoothly. Encourage the lady to relax and breathe deeply. What about the pain management by drugs? Suppose she's anxious, you need to give diazepam. That is diazepam 10 milligram oral tablet 1 hour prior to the procedure. Or you can give an IV dose 20 minutes prior to the procedure. 4 to 6 hours is the effect, but side effects are disorientation and dizziness. Or you can call an anesthetist and give an IV sedation or general anesthesia. Cervical dilatation will have to be done with drugs so that you reduce the pain. And for that, the local anesthesia is lignocaine, 10 ml 1% lignocaine, plaque for an hour, but it can cause dizziness, seizures, and gastritis. Analgesics, ibuprofen can be given 1 hour prior to the procedure in the form of 400 to 800 milligram orally, and that is it will have effect will be for 4 to 6 hours. And suppose she's got uterine cramping, you need to give ibuprofen, and that is 400 to 800 milligram 1 hour prior to the procedure. But remember, gastritis can happen. The steps of MVA: you always close the valve buttons, create a vacuum, keep the instrument ready, ensure pain control medication is given at the appropriate time, ask her to empty her bladder, perform a cervical antiseptic preparation, and then give the paracervical block 2, 4, 8, and 10 are the locations you give. Dilate the cervix if necessary, then insert the cannula. And when you suck, you have to keep the cannula inside the uterine cavity, but at least 1 to 2 centimeters away from the fundus. Rotate the cannula with a smooth, gentle portion, and then you release a vacuum button and it will aspirate the contents inside. And you will know that the uterus is empty when you see a red or pink foam without tissue passing through the cannula. You feel a gritty sensation of the surface of the uterus. You feel that the cervix is gripping over the cannula, and you see that the uterus is contracting around the cannula. The cervix or the uterus contracting around the cannula will tell you that the procedure is complete, but always put it in a bowl, inspect the tissue to see for the products. And concurrently, you can put an IUCD of necessary lab sterilization can be done. And then the instruments have to be soaked in chlorine solution 0.5%, which will be needed for the disinfection and helps remove the tissue and body fluids. Post-procedure, you have to monitor her for any complications and has to be managed accordingly. She may leave the facility when she's stable and meets the criteria for discharge, not use an anesthetic drug. Ensure that she knows everything about the procedure and the medications has to be given to her before she leaves the facility. Document all the outcomes of the treatment, including any adverse events, in the facility register and the client's record card. After care, the problems which you can have to be anticipated. There will be an incomplete abortion, infection, bleeding, or an ongoing pregnancy. You have to be very vigilant about that. You have to provide contraceptive information, offer contraceptive counseling and methods, assess for any other sexual and reproductive health needs that may require additional care. But if you have used only a misoprostol alone regime, she needs a routine follow-up, but may not be necessary if you use a mifepristone or misoprostol, because the completion is much better with a combination regime. So in summary, India has made an historic progress in improving the access to safe abortion. Not much has changed as far as technology is concerned, but as providers, it is up to us to ensure safety and quality, especially in the context of the amended law. Along with safety, focus on respectful abortion services. Every client, maybe a public or a private patient, should have an opportunity, should be given the opportunity to be informed, educated, and equipped with the proper information on contraception and counseling. Thank you so much for a patient hearing. Thank you.
Thank you, Charmila ma'am. It was nicely brought up, ma'am, about the methods, the side effects, the follow-up care, and finally it was well summarized, ma'am.
Thank you.
Thank you. Can we take up any questions, ma'am, from our members if they have?
Yeah. Yes.
So members, any questions to Sangeeta ma'am or Charminal ma'am? You can just unmute and ask the question. So I don't think so there are any questions. Shall we move further, ma'am, then?
There was one discussion on that case, no? I wanted to know, like, what was the gestational age of the fetus?
So that was by Sangeeta ma'am. Actually, the question started from, like, it was a case discussion by Sangeeta ma'am.
Yeah.
No, I was just asking, ma'am, if 24 weeks after a patient is coming, then from where to take? Because we are not having, I think, medical board till now. This was my question.
Medical board, you have to ask your government to form. They cannot say no. They have to form, because without a medical board, you cannot do an abortion beyond 24 weeks of pregnancy. And even in 20 to 24, sometimes you need their opinions when a patient comes. Like, we have got such instances, like not young, like below 18, we have got an indication in that you can go ahead and do between 20 to 24. But if she's above 20, not married, and comes around 20 to 24 weeks of pregnancy, what do you do? Because you cannot offer even under the amended law, because she does not meet the criteria of that 7 criteria. Then you may need to ask the medical board, and they have to give an opinion within 5 days, so that you can at least do something for her, because she will also have the same 18 and 19 does not matter, 1 year age or 2 years of this thing. So for that you need a medical board, definitely. And I think your society per se should put this thing request to the government to give you that medical board. Otherwise, put it on record. We asked for a medical board, you did not give, so I had to do because she came in an emergency. Like that you can say. But without us asking and they not forming, and we do what I've gone on the NIMC, the National Inspection Monitoring Committee's inspection of different states. I've gone, and they take those small changes in the, like, see, one person did not sign a form F correctly, a doctor, and for that they wanted to penalize. See, that is not wrong, because you could have missed it when you got 4 or 5 signatures in a single form. She could have missed one, but for that they wanted to penalize. They are bothered only about what the law says. So we have to also be very stringent about that. So you send them a request from the society, Raichur Society, saying we need a medical board for abortion services. Otherwise, unhealthy, unsafe practices are going to continue, and they can put
refer.
it. Even when you refer, and suppose you've seen that patient, sometimes something goes wrong, when they do that inquiry, it will come back to you.
Okay.
So everybody is going to have a problem sometime in their practice. So the best thing is put a request to the government or the local joint director of health services, get it in writing saying we will form, or you can go ahead and do. Then I think you should be this thing, because there are such different interpretations by everybody. We interpret differently, the government officer interprets differently, the law interprets differently. Then abortion services nobody will offer. Why should I get caught for an abortion where I hardly get 500 to 1,000 rupees? Why should I run about for that? Anybody will think so. And we did a study among almost like 2,000 gynecologists throughout India, and I did a study for FIGO on why gynecologists do not offer abortion services for second trimester abortion and young girls, unmarried young girls, because you've got the POXO act happening, you've got the guardian coming and signing for a second trimester abortion, and all that makes a gynecologist feel, why should I do? I will refer her. And when she has to go and stand in a queue in a government hospital, she does not want to do. She'll go to a nurse who will give her a mifepristone or a pharmacy guy who will give, and she'll end up with a complication. Who's creating that complication? The government of India is creating that complication. They are providing the drugs over the counter everywhere. They're not putting the law correctly, and they're not bothered about what's happening. So we have to tell them, see, I'm doing it correctly, and you are the one who has to help me, or just give it in record. And when you do it as a single person, they'll try to irritate you or penalize you. Should go as a society and do it. 10 people going together and asking, they'll have to listen to you.
Ma'am, like we are having that Foxy Society of Amritsar, it should be the responsibility of, I think, President and Secretary to get the state boards created.
See, government hospitals will not have problem. whatever complication happens, somehow the responsibility gets distributed. It will not go and come to that single practitioner. But the patient will not go to a government hospital for an abortion at the first point. She will try to come to a private practitioner. So the private practitioner, see, many of us are like sick of obstetrics now. It's become so difficult. So what we tend to do, we think it's easy and we start doing it. Then when the youngster, the one who comes into practice, will have to have a bread and butter only with abortion services. So somebody has to help them out. So you have to, as a society, medical board is not being formed. You have to tell the joint director or the director of health services, please help us out. See, we need not go and irritate them, but we can request them, tell them like, I will be in a problem if I'm not given this backup. So help me out. And many times we find the government officials will help when you go as a group and ask, because single practitioners going, they're thinking we're trying to earn out of abortion services. I tell them, this is what I've been trained to. It's not morally or ethically wrong for me to do an abortion when a lady is suffering. Nobody wants to abort a child which they want. They want to do it because of circumstances which has made them do. I am not the wrong person there. Because many times they'll say, no, you built your hospital on abortion cases and you did this and you did that. See, many of us do not do that unethical practice. So that the government has to understand. So because the person who does not talk is the one who gets caught. The one who does wrong will be very clear about the law and they'll maintain all the records correctly and nobody can point fingers. That will be that person who looks sorry and who's like so very strict in work and has been doing it is the one who gets caught. That's what you see in those NIMC inspections also. The person who's innocent gets caught. The one who's smart will get away with it.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, sir.
So, ma'am, we'll go with the next topic, WHO Safer Toolkit by Dr. Apurva Kumar Datta. Over to you, sir.
Thank you so much. First of all, I'm always great to listen and learn from Charmila ma'am. Thank you so much, ma'am. You have always given us the practical tips, which are actually beyond the, beyond our literature and very practical, which we gynecologists are facing. So thank you so much, ma'am, for sharing your ideas and values. So at the outset, I would like to thanks to the Raichur Society, the president and the secretaries, Hannah, for giving me this opportunity to tell all of you about what is the saver, and as a gynecologist, what is our the responsibilities and what all about the safe abortions values. So I just wanted to, before I start my lecture, I just wanted to state it and point out few things. First, when I always used to say, when in the 1960s, when the whole world are, blaming with we Indians that we always make our women's, the Indian women are very backward. It is a male-centric women's. They don't have the Indian women's don't have their rights. At that time, I am very proud to say that we Indians are the first of the whole world who even think of about the abortion's right of a women. And when the 1960s, when the Santilal Saha, commission was made, I'm very proud that Foxy was invited as a member, and our Foxy leadership was going there, and government always respect our values. So with these, initial talks, I would like to start what is all about. Now, the aim of this module is to define what is respectful abortion care. That is, what is the WHO standards, to highlight how the norms and stigma affect the services, and to provide WHO savior rescue for the respectful abortion care. Now, as I have already stated, that we are in an abortion, we have laws since 1970, we are talking about in 1960s. But why in 2001, there is so much, hue of about this respectful abortion care? Because the law has changed. In 2001, as ma'am has already stated, there is a major, change in the law of abortion care services in our country. Second, the Foxy, the largest provider care of the abortion, has given a momentum, and our leadership has given that we should train each and every OB-GYNs across the country who can give a respectful abortion care to the patient. And third, the online training is possible due to the COVID. So this is again a positive point of the COVID era, which already we are all suffering from that. But this one point is very positive of the COVID, that online training is possible. Secondly, MMA uptake is increased. The early safe and ensure no PCPNDT conflation should be there in the abortion care. The patient safety, respect, quality matters more than even, and we all have a role to play. Now, when we are talking about respectful abortion, what actually the respectful abortion care means, and how it is different from the normal abortion care. Now, it is adapted from the respectful maternity care recommended by WHO. The respectful abortion care referred to that maintain the safety, dignity, confidentiality, ensure freedom from harm and mistreatment, and enable informed choice and continuous support during and after all type of abortions. So in a simpler form, you treat and are treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history. That is, how many pregnancy, how many miscarriages, how many abortion, whether you are married or unmarried, which background you are from. If you ever feel that something is not right, speak up. As a health profession, it's our duty to listen and support. Communication is the key for providing the respectful abortion care. What are the norm and stigma? Now, what are the category of disrespect and abuse? It either in the form of the physical abuse or intimidating physically, like slapping, or verbal abuse, sexual abuse, stigma and discrimination, failure to meet the professional standard of care, poor rapport between the women and providers, and health system condition and constrictions. What are the right of every women's? Freedom from harm and ill treatment, right to information, protection under law, either in a form of MTP law or POSCO Act, informed consent and refusal, respect or respect for the choice and preference, dignity and quality of the care, right to timely health care, and to the highest attainable level of health, liberty, autonomy, self-determination, and freedom from coherence. These are the stigma and these are the norm. What are the various domains of respectful abortion care? There are basically 12 domains. Now, what are the domains? The first is being free from harm and mistreatment, maintain privacy and confidentiality of a woman, preserving women's dignity, respecting women's choice, engaging with the effective communication, that is the soft skill, providing information and seeking informed consent, ensuring continuous access to the support, enhancing the quality of the physical environment and resources where abortion care is carried out, providing equitable abortion care to each and every, irrespective of ethnicity, socioeconomic condition, the pregnancies, abortion, previous abortions, and we have to take care and give the equitable abortion care. The availability of the competent and motivated providers, provision of contraceptive advice and commodity security, continuity of the care and the counseling. These are the 12 domains of the respectful abortion care. Now, what is the time? It's a time to strengthen the implementation. My dear friend, it already very beautifully explained by respected Charmila ma'am. The important change for the provider opinion that every patient is an opportunity for respect, and as a provider, onus is on us to educate and to reduce the sex selective abortion. The 1 RMP when it's up to 20 week of gestation, 2 RMP between 20 to 24 week of gestation, and beyond 24 weeks, there should be a medical board. So abortion can be done at any age of gestation, but beyond 24, a medical board is required. Second, the expands the eligibility, especially the young people, survivor, unmarried. Everyone need unbiased care, and we need to overcome our own bias. That is all women up to 20 week of gestation, up to 24 week of gestation in case of special categories like rape or less than 18 years of age. But yes, we have to keep in our mind about the POXO Act and birth defect in any of gestation age. But yes, medical board certificate is required. Prioritize confidentiality and safety, respect budget, respect the care provider. We need to be mindful of the socio-cultural aspects, name and other particular of any women seeking abortion to be confidential except to the person authorized in any law for the time being enforced. The ground of failure of the contraception have been extended to women and her partner. So, my dear friends, treat a lady who came for an abortion with the respect, quality, and dignity at all type of abortion, irrespective of gestation age. But we have to keep in our mind the POSCO Act, the MTP Act. Now, go into avoiding stigmatizing language. So what the WHO is saying, we have a very wonderful 2 videos. After this lecture, I will share you the videos. And so the final words that from 1970, when there is a law for unsafe abortion, to 2000, the safe abortion, and now in 2020, the respectful abortion. This is the main motto. So before we coming to end, I would like to discuss with you some questions. Now, according to WHO, restriction access reduces the number of unsafe abortion. What's your interpretation? Yes, the answer is false. Why? When we called it as an unsafe abortion, the safe abortion, when by it is a proper, appropriate method and by the trained person, then we call it as a safe. If only one criteria is met, then we call it as a less safe. And when both the criteria are not met, it is known as the unsafe. So the restriction to access to abortion is actually increases the number of the safe abortion, as ma'am has already stated, the Charmila ma'am, that due to fear, we gynecologists are not treating, and they are getting over-the-counter medicines or by some quacks, and here's come the problem, and the complications arises in the abortion. Next question is 30-year-old women recently widowed want to get an abortion at 32 weeks. As a provider, it is our responsibility to tell her to continue this pregnancy? Absolutely no. Yes, we have to respect their choice, what they want to do. Yes, but yeah, you have to tell them what is the pro and cons of the abortion, but we should not impose ki nahi bhai, you have to abort, why you are going to abort, it should not be done. If it is come under the law, you have to advise, you have to give the abortion care service to the lady. So the responsibility, we should not impose our ideas on the patient, but we should respect the idea of the patient, and that is the ethos of the respectful abortion care. So in India, abortion is legal. Let us make it safe and respectful. Samarth Bharat, Sampoorn Bharat. Thank you so much for your kind listening.
Thank you, Apurva sir. It was really a nice talk on respectful and how we should give respect to an women who wants abortion in all the circumstances and criteria. Thanks a lot, sir.
Thank you. Susma madam, before that, I just wanted to share 2 very important videos. Sriman, can you do the needful?
Yes, sir.
A wonderful videos by our Foxy leadership, and I must thanks to our leadership. because they have taken on those, pain to, teach us and to train us for this. Yeah, Sriman, over to you.
Is my screen visible, sir?
Yeah, Sriman, it's visible. Yeah,
Yeah.
go ahead.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and/or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally. How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex-selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high-quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 Ps provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high-quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex-selective abortion is illegal. Provider and place need to be safe, trained, and certified.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Seva has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Thank you so much, Sriman, for this wonderful video. So I would like to back to organizer for the next lecture. Yeah, thank you.
Sir, it was
Sushma,
really
yeah,
very
over to you, ma'am.
informative video, sir. Really, thank you for playing the video, sir. It was really very informative. Thanks a lot, sir. So we will go on with the next topic, that is pre and post abortion family planning counseling by Dr. Swarupa Rani Akula. Over to you, ma'am.
Yeah. Good evening, everyone. Shriman,
Yes, madam.
yeah, how to share?
Click on the share button, madam. Or should I do it for you?
Yeah, please. Already I'm on the share button. It is Microsoft OneDrive or?
No, just give me a minute. I'll share, madam.
Yeah. Yeah, good evening, everyone. Today we'll be talking about the post-abortal contraceptive advice and care. This is the right time once a woman is with us for a respectful abortion care. This is the time we can sensitize the woman regarding the necessity and need for the contraception. Yes, can we go with the next slide? Counseling is the best part, and that can really motivate the woman for the contraception. Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. Next. Shrima, next slide, please. Yeah, pre and post-abortion counseling involves integral part of comprehensive abortion services. As important, it is as important as the procedure. The woman may need some help in decision making, which the healthcare provider has to give. Wherever needed, the spouse should also be counseled. Next, please. Yeah, the pre-procedure counseling, the critical role. The woman needs help about deciding about the termination of pregnancy. We have to help the woman to choose the method of termination, and we should ensure that the delivery of complete information about the procedure is given to her, and we should help the woman to adopt a contraceptive method. Next. Ensure privacy and confidentiality. As we have already listened from our previous speakers, but confidentiality is the most important thing. We should be non-judgmental and at the same time be sensitive to what the patient is telling us, establish good rapport with them, and use simple language and allow the woman to clarify her doubts If she has made up her mind for termination of a pregnancy, assess her for the procedure. Next. The relevance of peri-abortion family planning counseling. There are 4 things here. We have to counsel the patient about the quick return of fertility, which is as early as 10 to 14 days to 1 month. And it is an opportunity time for contraceptive acceptance. The patient will be in a receiving mode to accept the contraception. And minimum 6 months gap before she plans her next pregnancy should be given. Health benefits and better future pregnancy outcomes have to be discussed with the patient. 90% of abortion-related maternal mortality can be prevented by ensuring contraception. Next, please. Sriman, I'm seeing one black bar down there. Pre-abortion FP counseling. When to start? The first visit or the consultation visit is the best time to counsel regarding the contraception. Exception when if the patient is in a grief, delay the counseling. What to counsel? Return of fertility, 10 days to 4 weeks, as I've already said, and help her with the choices of contraception, which suits her the best, and method of specific contraception, whatever contraception she chooses, counsel about the methods. And whenever there is a high risk behavior, you have to counsel about that also. If the woman is not willing for any contraceptive method, even if she refuses to take any contraceptive method, do not refuse MTP. This is utmost important. Our aim is to give a safe abortive care to the woman. Try and counsel her after the procedure. If she's still not willing, call her for follow-up in a week's time and counsel her again. Next slide. The black bar again. Assessing suitability for post-abortion care, post-abortion contraception. We have to first ensure that the abortion process is complete. No existing infection is there. No injury to the genital organs. Chances of fresh pregnancy should be ruled out. Next, please. Next slide, please. Post-procedure counseling, critical role. Ensures woman has, this post-procedure counseling ensures that the woman has understood precautions and care needed during post-abortion period. This is the best opportunity to counsel for contraception in case she did not accept it previously. It reinforces the need for continuing the use of contraceptive method chosen. Next. Post-procedure counseling. Continue to ensure privacy and confidentiality even after the procedure. Reassure the patient. Repeat the information about post-procedure care and danger signs. Like if she has any continuous bleeding or any other problem, she has to come to the doctor. Post-abortion family planning counseling involves, if she has already adopted some family planning method in the very first visit, appreciate that and give her the immediate care, whether she, whatever method she chooses. It can be an intrauterine contraceptive device or some pills, or you have to follow up her with the protocols. And again, continuity, saying that these contraceptive methods have to be continued uninterruptedly to prevent unplanned or unintended pregnancies in the future. If she is still undecided about the contraception, you allay her anxiety first, counsel her, saying it is important to adopt one of the methods of the contraception to prevent unintended pregnancies. And this has to be continued for extended periods. And the couple need to be counseled at times when they are not able to decide. And we have to counsel them about the emergency contraceptive pills also. Next slide. Post-abortion contraceptive methods. What all can be given? It can be the barrier method, the condoms. In the first trimester, second trimester, we can give it as soon as the abortion process is completed. And as this is a non-hormonal method, no side effects. It can be used without consulting a health provider, and it is easily available. And it also has an additional advantage of preventing the STIs, including HIV, and it enables men to take the responsibility of contraception, breaking the gender stereotyping. Next slide, please. Coming to the intrauterine contraceptive device, even in the first and second trimester, we can give the IUCD as early as 12 days. But make sure the procedure is complete and all the contraindications like infections and other things, genital injuries are ruled out. It is highly effective. It provides long-term contraceptive. With the IUCD 375, it gives 5 years protection. With IUCD 380A, as long as 10 years. It can be provided by trained doctors, MBBS and above, ANMs, nurses, after the first trimester surgical abortions, by trained doctors only after MMA, and by PPIUCD trained doctors after second trimester abortions. This has an advantage that there is no interference with sex, unlike the condoms, no immediate return to fertility on removal of the IUCD, and there are no hormonal side effects. Next slide, please. The combined OCPs, this can be given as early as 7 days after the abortion procedure, either by a surgical method or MMA. And again, here also we have to confirm the completed abortion. This regulates the menstrual cycles. The OCP, COC regulate the menstrual cycles. It can be provided by all health workers after first screening by a trained provider. There is no interference with the sex. Offers protection against ectopic pregnancy, endometrial and ovarian carcinoma, and benign diseases such as fibrocystic and fibroadenomatosis, not suitable for women who are breastfeeding, who have breastfeeding babies less than 6 months. Next slide, please. Post-abortion, we can advise the MPA, that is medroxyprogesterone acetate, immediately or up to 7 days after abortion, either surgical method or MMA. It can be started on day 3 with a dose of misoprostol. Highly effective, confidentiality and privacy is maintained, can be provided by MBBS doctors, Ayush, ANMs, nurse after screening by the doctors, MBBS and above for the first injection. No interference with sex, no effect on the quality and quantity of breast milk, no estrogenic side effects, offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. Next slide, please. Yeah, the permanent methods, we can counsel them if they have completed their family and they are willing for a permanent method of sterilization, which can be a female sterilization, bilateral tubectomy, either by a mini lap or laparoscopic sterilization up to 7 days, or mini lap sterilization can be performed concurrently along with the MTP procedure or up to 7 days. It is a permanent method of contraception. It is highly effective immediately, no interference with sex, no effect on breastfeeding, no long-term side effects, offers protection against ovarian cancer. And coming to the male permanent method of sterilization, vasectomy, it is performed on males independent of the timing and procedure of the abortion. It is very effective. It is a permanent method of contraception, no interference with sex, no long-term health risks. Couple must use another contraceptive, the barrier contraception, for 3 months or till the sperm counts come as azoospermia. Next slide, please. Yeah, in the COC pills, we can start as early as 3rd day and can be given up to 15 days. The injective MPA can be started as early as 3rd day and or later on. And the IUCD also up to 15 days, tubal ligation anytime. Next slide, please. Next, yeah, COC can be given, injections can be given, the centroman can be given, IUCD can be given, the tubal ligation also can be done. Next. SRH services include the teleconsultation and other technology. Next slide, please. Unlike the previous days where we had to do physical examination, now we have this facility of teleconsultation and telecounseling, teleguidance, telereference, telelinkage, thanks to the COVID times, which has allowed us to innovate this service provision by leveraging the technology. Next, please. Yeah, we have this techno IEC things, like we have website Hamdo, where you can get all the information about this contraception. Social media, we have Ask Tanu, YouTube, infographics we have, helplines we have, and we have patient education platforms from WHO, MOHFW, RCOG. Next, please. SWOT of teleconsultation. It is a strength in the COVID era, approachable throughout the process, and it is confidential, and awareness is spread out easily with the questions answered at ease. Weakness, face-to-face demonstration, and it is opportunity, privacy and comfort is there, cost saving is there, number of visits are cut down. Threatened, the threat is it is a missed opportunity and misdiagnosis. Applicability of components of CAC. Assessment. Here we have to first confirm the diagnosis and give the contraceptive need. Counseling, it can be video conference or a Zoom meeting. Follow-up, we can have hybrid services. 1 visit, and for the MMA, 3 visits. Next. Key messages. Realize the need of post-abortal family planning. Bring the couple on board and strive for 10% coverage. Capitalize on the basket and applicability in post-abortal period. Technology as far as possible. Scope for entry in CAC services. Concern, policy, malpractice, service cost, access have to be cut down. Adolescent reproductive health needs both online and offline counseling. Next slide. Next slide, please. Yeah, we have to give this registration pre and post test and feedback to generate a certificate. All the participants who have attended this program will get a certificate from WHO. Next. India is having the safe abortion and legal abortion. In India, abortion is legal. Only gender biased, the selective sex termination is illegal, but abortion is legal in India. We all have to try for it. And thank you for giving me this opportunity. Any queries, we will address.
Thank you, Swarupa ma'am. It was really a good talk. And as you told, it is really pre and post abortion counseling is important, and it is as much as needed like a safe abortion. Thank you, ma'am. Any questions shall we take up, ma'am?
Yes, please.
Yes, ma'am. So, Foxy members, any questions to any of our faculty? Please unmute and you can ask the questions.
It indicates whether they have understood completely or they didn't understand anything.
Nothing.
It was really a nice talk by all the 4 faculty.
So there should be clear message also that emphasis should be not only on the safe abortion, but also right to the privacy and reproductive control also.
Yes,
so this
very
should be the
important.
message. Yeah, very, very important. Otherwise,
And I think-
adolescent and unmarried girls will go like anything. So reproductive control is must.
Yeah, that is good. That is the role of contraception. As our slides have clearly mentioned that
Yes.
abortion is not a method of contraception, and contraception has to be adopted to prevent these abortions.
Correct.
Very important, especially the unmarried girls and the young girls, they should adopt this contraception. whenever we get a chance, we should counsel the younger generation, even before their marriage, to adopt this contraception. That is the essence of this talk. Yeah, and Sriman is forwarding a link for the post-test. All the participants, we request you to take the post-test so that you will get the certificates. Please do that. Maybe Sriman can help you with what to do. Sriman, please take it.
I have posted the link in the
Swarupa,
chat.
ma'am. Yeah. Ma'am, I fully agree with you. And really, there was when the new MTP Act was there, it came, and it was a great hue that MTP Act and POSCO Act is somewhat, contradictory. And since we are, practicing in very small city, and it's a very, third or fourth tier cities, so we always and often get a very young patient with, like even married at the age of 17. And they are coming with, pregnancy with their husband, with their family. And if we are going into
Even then they are
again
coming
into
under
the law,
POCSO Act. Even then they are
POCSO,
under
and
POCSO Act. Yes.
yeah, that is the thing. If we are informing everything to the police that yeah, they are coupling, that patient will not turn up with us. That is, I
No,
think so.
recently, yes, Dr. Apurva, one patient came to us recently. She was 17 years old and she was term pregnancy. When we said we are going to
Exactly.
inform the police, they ran away immediately. Immediately they
Exactly.
ran away. Yeah, because even if
So
she's married, she's coming with a husband, all the families. Even then, it comes under POCSO Act if she is under 17, married or unmarried, both.
what I feel, ma'am, these type of situations are more in the social problem than into the legal problem. And that is, we think, we should understand this. Because in a big cities, yeah, we can, but we often get, even I am working in Jharkhand in a small place in Dhanbad, that too outskirt of Dhanbad. So I'm often get a, 16, 17-year, with a pregnancy, they are married with a pregnancy and with the family. And if you're going to report everything the police, then the patient will not.
No,
That is the thing.
here the clever thing maybe. See, there are two things, Dr. Apurva. What is legal and what is safe is first question. What is safe for the doctor? The second question. First, save your skin, then you can talk of anything. See, when
Correct.
it comes to legality, nothing can save you but the law. So
Law.
you be bound by the law. You be bound by the law and let the things take the shape. You can't just say that I'm losing this patient, I will do it. That is not correct. See, POCSO Act is really very serious. Even if the girl is married at 17,
absolutely.
even the girl is married at 17, you have no right to terminate or deliver the patient without informing the police. So this message is very clear. So everyone has to, if you think by informing the police, you will be into problem, don't treat the girl, let the girl go to some government institution wherein they will take the proper action and you will not be penalized, like you will not be cornered. Because you're a single doctor, maybe they will point at you. Being a small area, everyone knows you, or if you have to get into some problem, maybe that is the best way you can avoid the problem. Right?
Exactly, ma'am. Thank you so much. Yeah, it's really a very genuine.
Even I am working in a facility where we come across these things very commonly. So, yeah.
So, thank you so much, ma'am. It's a wonderful discussion. Yeah.
Any more things?
I've posted the link in the chat box, madam. The post-test link. You just click on the link. You'll be redirected to the page, and you can answer all the questions. Submit. Then you'll show the submit. Then we test.
Okay.
Ma'am, what you are doing on the files, you are doing the coding or you are writing the names?
Actually, you are supposed to give a code. Maybe you can have the coding data with your personal records. But on the files, you're not supposed to give the names. We have to practice that as per the new amendment.
And coding, whatever we can start coding, A, B, C, D, or 1, 2, 3, whatever we want.
Yeah, you can give according to your hospital.
Yeah.
According to your, suppose your hospital name is something like Prerna. So you can give PRER.
I am working in medical college actually. I am working in medical college.
Then maybe your team should sit together and then finalize what to be
Actually,
given.
when patients of the insurance are coming, then it creates very problem. Coding creates problem when patient is insured.
In government medical college and you're asking for insurance,
No. It's not our medical college. It's private medical college. SGRD medical college is private medical college, and insurance patients are coming here.
That is the matter to be looked into by your management. It's not a single doctor's responsibility. So you talk to them, let them sort out something for them.
They are saying whatever you think as
MDP, I don't think will be covered under insurance, so it should not be a problem. As per my knowledge goes,
it is covered. It is covered, I think.
True? Yeah. No, I don't think so. I'm not very sure.
Because here deliveries and cesarean, everything is free in our hospital. Because that Janani Suraksha user, everything is free. But MTP tubectomy, everything is charged, and insurance is covering that MTP also.
Okay, I'm not aware. If that is the case, let your management decide what to do with that.
Because they are without name, they will not give the insurance money.
No, I understand, but your management has to decide on that.
Yeah.
You're a thing. You're just.
Otherwise, coding should be done on the file.
Yes. Yes.
And what about the wife of what all that?
Say you're giving one number. See, if you're giving, say, some Sunita has come to you. Her number you have given as a coding as 64 example. So for 64, all the data will be there with your records. It won't be on the file.
On the file, we are not going to write anything except 64.
That's all. Your consent form and all that, they may have the identity and everything.
Sign that will be signed.
That all is again confidential. On the file, you will write only 60.
Only
and
60.
all the data is with you. Example.
Okay. I think there is no questions.
Sriman?
So any questions from Foxy members? I don't think so, ma'am. So, ma'am, coming to the end, at the outside, I would like to thank all the 4 faculties for taking their so much of time and giving us so much of information, which was a need of an hour. Thanks a ton for all the faculties, ma'am. And I also thank Dr. Mangla Gadwal, ma'am, who is the president of Raichur Obstetrics and Gynecological Society, and all the Foxy members who have joined today. And finally, I want to thank Shriman, who was supportive and coordinating for all the program.
Welcome.
Thank you each and everyone.
Yes. Thank you one and all.
Thank you so much, Dr. Sushma, for such a wonderful session. Thank you so much, Dr. Sushma.
Thank you, ma'am. Thank you.
Thank you, ma'am. Thanks.
Thank you, Swarupa, ma'am. Can we leave now?
Yeah, that's what I was just about to ask.
Yeah.
Yes, ma'am.
Sriman, can we call it a day?
Yes, ma'am. Yes, ma'am. You can.
Thank you, Sriman.
Thank you.
Thank you
all
so
the
much,
faculties and the members. Thank you, ma'am.
Have a nice day.
Bye, Sushma.